Good morning, students, or afternoon or evening, whatever time of the day you are watching this. So we're embarking on a new module and we need to start talking about new ideas. And so we're going to talk about frozen sectioning. And you're going to hear this just simply referred to as frozens. So frozen sections. Why is it that we do frozen sections? So frozen sections are our time limited activity that we do in the workplace. They are done when there is a patient on the table, in the OR, and the surgeon has removed a tumor and wants to make sure that the margins of that tumor are clean. Yeah, meaning that the pathologist, we're going to ink the margins, and the pathologist is going to look at those margins and make sure that there isn't any positive tumor cells, cancer cells at that margin. If there is, the pathologist will call back into the OR and tell the surgeon that they need to take more tissue from that patient to remove the entire tumor. So the patient is still open on the table, and they are awaiting us to do our job and to deliver those results to the patient. So what will happen is that tumor is removed, it gets put into a bag or a container, and then there's a runner that runs from the OR to the histology lab. Once the frozen section is received in the histology lab, we have 8 to 10 minutes to perform our job. That's the expectation, until the pathologist can call back into the room. The reason that we have this expectation of a very short time is because the patient is still under anesthesia. And the longer a patient is under anesthesia, the more dangerous it becomes for that patient. And if this patient actually does have a cancer, then, there's the possibility that this patient is going to have further surgeries. Yeah, and so they want to limit the time that the patient is exposed to anesthesia. So the patient, the surgeon, all the nurses are just kind of standing in the OR while this patient is open on the table awaiting results to be called back into the OR before they know what to do from that point. Another reason that we do frozen sections is to perform immunofluorescence and enzyme histochemistry. Yeah, during processing, the heat and fixation actually inactivate the enzymes and the antigens that we need to tag to perform immunofluorescence and enzyme histology. So we can't do these two tests on formalin fixed processed tissue. Yeah, so the fixation will inactivate, and then the heat on the processor and your paraffins will inactivate as well. We've talked about formalin masking. So we can actually open the binding sites for immunohistochemistry on a paraffin embedded tissue. Yeah, but if we're talking immunofluorescence or enzymes, we can't do that. The other reason we do frozen sections is for fat demonstration. As you know, the processing removes the lipids, and it's the absence of the lipids that tells us it was a lipid in the first place. So if we're actually doing a true fat study on the amount of fat cells that are present in a particular tissue, then we do that on a frozen section so that we can literally stain those lipids. So there's a couple of different ways to freeze tissue. The most common way is in the cryostat, directly inside of the cryostat. Again, the cryostat is a microtome that's just held in a -20 degree freezing chamber. So Although there are techniques that can be done quicker than freezing in the cryostat, the quicker that we get the tissues frozen, the less artifact that's created. And the artifact that we create when we freeze tissues is simply that. It's called freezing artifact. The Even though that we can use isopentane and liquid nitrogen to freeze a tissue and it freezes the tissue quicker, we still have to operate, within the cryostat to collect that section. So oftentimes, you're not going to be snap freezing at what's called snap freezing with the isopentane and the liquid nitrogen. Because there's ramifications to it, yeah, that we'll talk about in just a second. 90% of the time you're going to be freezing directly in the cryostat. Now, if you are snap freezing, the protocol for that is you're going to take some isopentane. You're going to have on metal gloves to protect yourself. And you're going to pour a little bit, and the bowl is just a little round metal bowl. And you're going to pour a little bit of isopentane into that metal bowl. Then you're going to lower that bowl down into liquid nitrogen until it reaches minus 150 degrees Celsius. Then you're going to you'll pull that isopentane out of the liquid nitrogen and you place the tissue into the isopentane and it will just freeze instantly. Yeah, and then you pull that tissue out, and you put it in the cryostat to cut it in the cryostat. So at the very beginning of the procedure, before you're even in the cryostat or you're freezing in isopentane, the pathologist himself is going to gross this tissue. So this tissue is going to come into the histology lab. There'll be a bell maybe that's rung. Somebody will yell frozen. And whoever it is that is on frozens that day, the HT, will go accept that frozen. They will pull it out of its container and put it on the grow station. And then they'll take the requisition, and there's usually a time stamper in the histology lab. So they'll take the requisition that's accompanying the specimen and they will time stamp it, so that we can track our timing and make sure that we're within that window, that acceptable window. Now, the pathologist will be notified that a frozen has arrived. You'll notify the pathologist. The pathologist will come in and the margins will be inked. And then, make sure you pat them down with a paper towel to remove the excess ink off of the specimen. And then the specimen is grossed. And the pathologist will determine which section they want frozen. So once the section is obtained by the pathologist, they're literally going to turn to you and hand you the tissue for you to start freezing it. At this point is when the pathologist can give you any type of direct information or instructions at that point in time. They may point out a particular area of interest on that particular section. They may point out that I'm really looking at this, inked margin. They may tell you that they want 3 levels on this particular frozen section. So that's when direct instructions are given, when the handoff happens from the grow station, from the pathologist at the grow station to the HT that's going to freeze the specimen. So this is what it looks like inside of the cryostat. So this right here, this is your specimen inside of what's called OCT. OCT is a freezing medium, much like your paraffin that you would normally embed a tissue in. Instead, you're going to embed it in this medium that is quick freezing medium. Over here on the side, this is where you're going to do your embedding. Yeah, so you have little molds that you are going to, or they're called chucks, that you will put on these little squares. Yeah, and then you'll put a little bit of this OCT medium on that chuck. And when it starts to turn white and starts to freeze at the bottom, that's when you're going to take your specimen and you're going to embed it in that OCT. Once you get it situated how you want it in that OCT, then you're going to take some more OCT and put over the top of it. And then right here is a little swing, and there's a thing that's attached to this that's called a heat extractor. It's like a little hammer, and you just place that little hammer on top of the medium that you put over the top of the specimen. And what it's going to do is it's going to suck the heat out of the OCT and freeze that tissue quicker for you. And it's also going to give you a flat surface on the top to deal with when you start cutting. Once it's completely frozen, so it takes a little bit of time for it to freeze. While it's freezing, you close your door, and that up here, there's a little shelf on your cryostat. This is where your slides are kept. So while this is freezing, you'll pull your slide and you'll label your slide, and get it ready to immediately pick up, once you get that section off of the tissue. When you label your slides, there's the possibility that it will not have an accession number at that point. So you're going to label your slides with the first initial, last name, and the date that you're cutting, and your initials. So once this gets, and then you're going to lay your slide up here. Now I lay my slide with the labels sort of sticking off the ledge right here, so that when I'm in here cutting, you kind of hold your specimen down. I'll get there in a minute. But when I'm down here cutting, I don't have to take my eyes off of the section that's laying right here. I can just simply reach up and grab it and collect that specimen. So this is your knife holder. It's exactly like the knife holders on your microtomes. There's a lever right here. This is the area that unlocks your blade. So this is the area that you're just going to slide your blade into. This over here is what changes your clearance angle. And then this is just like the chucks in your microtome. The only difference is that the chuck that the specimen is mounted onto has a peg on the back of it, and this little round peg sits inside of your microtome chuck. And then right up here is a screw. So you unscrew it to open it up, and you stick the little hole in the peg, and then you screw it down to tighten it. Your actual fine feed is on the outside of the microtome on this side. And then your gross feed is a button on the outside of the cryostat. So why don't we always snap freeze if it produces the best results, because it freezes faster and it eliminates that ice crystal artifact, freezing artifact. And the reason for that is because isopentane is very, very flammable. And remembering that when you're dealing with liquid nitrogen, it immediately freezes something. So there's additional risk of injury to the HT by potentially freezing their finger. And then there's also the fact that, some people are very susceptible to cold. Yeah, in that, you can actually get frostbite on your fingers, from doing this procedure. The liquid nitrogen and isopentane is very, very expensive. Yeah, and in order to have liquid nitrogen in your laboratory at all times to do this, it requires constant deliveries because liquid nitrogen evaporates extremely quickly. So about once a week, you have this delivery guy that's coming into your laboratory to fill up your liquid nitrogen. And of course, there's HIPAA ramifications wrapped around that. So for us, the biggest hazard to cutting in the cryostat is airborne pathogens. Because we're dealing with fresh tissue, and we are able to aerosolize diseases that are in the tissue. Now, really the only disease that we worry about, which isn't, it has to be an airborne disease, first of all. So really the only disease that we're worried about is tuberculosis. And tuberculosis exists in lungs. Yeah. So most of the time, if somebody is looking at, a doctor or surgeon is looking for tuberculosis, they're very aware of the airborne factor. So it will be fixed and stabilized in time so that it doesn't hurt us. And then we will go through the paraffin embedded process. And you don't have to worry about it through the paraffin embedded process. Yeah. So if tuberculosis is in fact suspected, yeah, it would be in a lung tissue. So it's really easy to, sort of determine, oh, maybe I should put some extra precautions on, because I'm cutting a lung. And so those would be, wear a mask when you're cutting it, wear your goggles. Of course, you're always going to be wearing gloves when you're doing this. And there's also this thing that's called freezing spray. And it's much like, you're an aerosol, right? An air freshener or the spray that you spray your keyboard on your computer with, except that it freezes things when it comes out. Never use freezing spray in your cryostat ever. Yeah, because it will aerosolize tuberculosis. Plus, yeah, all the goop that's inside, the raw goop that's inside your cryostat is going to get blown out of your cryostat. Yeah, and you're going to have a mess that you need to clean up. So most of the problems that happen during freezing in the cryostat are the prep of the actual specimen. So again, we have ice crystal artifact. That ice crystal artifact comes from the histologist not moving quick enough inside of the cryostat. Yeah, and what it does is it produces these little holes where ice has accumulated. Yeah, and then the ice melts away, and so you have these little shards throughout your specimen. Yeah, so to prevent this ice crystal artifact, yeah, you need to use that heat extractor. And then on the left hand, no, it's up top. When you close that cryostat door while your specimen is freezing, there's a little blue snowflake that's up on the back of the cryostat. If you hit that, that snowflake is going to drop the temperature of your freezing bar over here so that your specimen will freeze much faster than -20. -20 is what the cryostat is always set on. And this will drop it like significantly down to like 36 immediately, -36 immediately. And then, don't try to educate your people. Try to educate your people in the OR. Some people will send down a specimen in a fixative and want a frozen on it. Well, we can't really do that because, we're talking NBF and there's a bunch of water in that NBF. Yeah, in that instance, the pathologist is going to have to determine whether they want a frozen or whether they're going to call into the OR and defer to permanent. That's a common term you're going to hear in frozen sectioning. It's called defer to perm. The defer to perm is two sort of things. It's when the frozen arrives at the histology lab and, it's been put in saline, or it's been put in a fixative. And, we prefer to not put that, or maybe it's a lung tissue that's suspected for tuberculosis. We prefer to not freeze that specimen and do a frozen section on it. So the pathologist will make that call. And if that's the case, he'll call back into the OR and say, I'm going to have to defer this to perm, meaning he's going to defer the frozen to a permanent section. Sometimes you may get a frozen that's sent from another facility, and they have gone through the thought process of, oh, I'm sending this to you, so I'm going to put it into saline, which is a acceptable transfer method if we're talking about permanent sections. But if we're talking about frozen sections, it's not a great transport. Sometimes you are going to have to send out a raw tissue, and mostly it's muscle, that you will receive in the lab for frozen. There are very few labs that actually have the ability to freeze muscle because it is what they will do is they will snap freeze it, and then they're going to do enzyme histology on it. Yeah, so if you have to send a muscle out, what's going to happen is it's going to arrive to you on a tongue depressor, and it's going to have two little pins in it, and you're going to have to send it usually to Seattle Cancer Care Alliance or the University of Washington. Don't ever immerse it in saline. What you do is you take a saline wet gauze pad and you wrap it around that muscle, and then you take the whole tongue depressor and you stick it in a bag and you seal the bag, and then you send it as soon as possible to whichever facility you're sending it to do the enzyme histology. And then the last thing is that you can potentially utilize snap freezing if your lab does it. Now, again, most of the time you're going to be working in the cryostat as opposed to snap freezing. So when you lay your specimen into that OCT, wait for the OCT to get this little sort of white film on the bottom of it. Then take your specimen and push it down into the OCT. You need to make sure that your specimen is laying flat, just like it in bedding. You don't want it to be like this, you don't want it to be like this. You want it to be laying flat so that you can get that full face when you cut it in the microtome. So to help you with that, use that heat extractor. There's also another thing that's called the slide technique. And there's another thing called using OCT platforms, and we will get to that. So your heat extractor is located on the inside of the cryostat. It's on the left-hand side. It's like a little hammer. looks like a swinging hammer. Yeah, and it's going to extract the heat out of your OCT, and it's going to flatten your tissue. It's much like the tampers, that embedding. It's going to flatten your tissue, so that you can get that full face when you cut it. Now, the slide technique is a little bit different. So when the pathologist hands you the specimen, you're going to take a slide and you're going to put that specimen on the slide. Then you're going to surround it with OCT. That, again, that's your embedding medium. Then you take that slide and you place it down in the cryostat. And now you're waiting for that OCT to turn white in the cryostat. While you're placing, you're waiting, right? Then you can put the chuck on top of the OCT. And then let it freeze completely. And then once it's completely frozen, yeah, you can then pick it up, and now you have the peg down here, and you have the specimen in the middle, and you have the slide up here. So then you can just take your finger and slide it over the back of the, rub it over the back of the slide, and then gently pull that slide off the face of the tissue. And now you have a flat surface, that where the slide was. So you have a direct flat surface. And then you can take the whole peg and put it in the chuck and start to cut. Then there's this thing that's called OCT platforms. So this is when you pre-make platforms. So you take your chuck, and you put them in the cryostat, and you put the OCT on it, and you just let the OCT freeze on the chuck. And you place that heat extractor on the top of it, flatten it out with that heat extractor. And then you pull the heat extractor off of them and you leave those in the cryostat. That way, when you get a frozen in, you just take the tissue and you put it on top of the already frozen OCT, and then you can surround it with a little bit more OCT, put the heat extractor on it, and your specimen's going to get squeezed into those two platforms, and it'll freeze quicker. Yeah, and it'll have a flat surface to it, so that you can then cut it. The problem with OCT platforms is that if you pre-build OCT platforms every morning, you have to remember to remove them at night. Because the cryostat automatically every night goes through a thaw cycle, and that thaw cycle is intentional so that all of the OCT that may have built up in the cryostat will melt, and it drains down to the bottom into this little hole, and this little hole goes down into a tub, to be collected and disposed of later. So if you're not removing those OCT platforms, you're going to come back in the next morning and you're going to have this big old frozen OCT mess inside of your cryostat. So, just general information. Again, your course feed, it depends on your cryostat. If you have an older cryostat, the course feed is going to be inside the cryostat on the back of the microtome, and you're going to turn the wheel inside of the cryostat. These days, most of them are much fancier. So you have your specimen in the chuck in the microtome, and there's just a button. You just push the button, there's an arrow forward and an arrow back, and that's your gross feed. So it'll go backwards for you, or it'll go forwards for you. On your right-hand side, is your fine feed. So it's got a lock on it, just like your microtomes. And it will, with every turn, it's going to turn that, bring that chuck forward to your blade. Now with Cryostats, we cut at 8 to 10 microns, not 4 microns. That's sort of our routine thickness. Yeah, there are times when you're going to need a thinner section, and that's when we're talking about enzyme, special studies, enzyme histology. So your knife angle inside of your cryostat is usually set right around 30 degrees. It's just like your microtomes. If it's too great, you're going to hear this scraping sound. If it's too small, you're going to get these thick thinning sections. It's the same troubleshooting as your other microtomes. Yeah, you need, once you turn your cryostat on, you need to maintain documentation via the taskmaster, that your cryostat is being kept at minus 20 degrees Celsius. And you always want to keep the inside of your cryostat free of debris, just like, your usual microtome. You don't want paraffin everywhere. So you don't want that OCT everywhere in your cryostat either. So how to keep it free from debris. When you're done, there's brushes in the cryostat. There's a big brush, there's a couple little brushes. Yeah, you just take that big brush and you sweep all the stuff down into the bottom of the cryostat when you're done using it. And then you can actually take a piece of gauze or a paper towel, and moistened by 100% alcohol. And you can just get into the bottom of the cryostat, grab all that free debris, wrap it in that paper towel, and then throw it in your biohazard waste. Now, please be careful. Carson is going to tell you to wipe your cryostat with 70% alcohol. Please don't ever do that to our cryostat. Never, ever introduce any type of water into the cryostat, because you're gonna decontaminate your cryostat. But if you're wiping it, the reason she says to wipe it with 70% alcohol is because that's the best disinfectant. However, if you are putting 70% alcohol inside the cryostat when you're decontaminating it, you are introducing 30% water. And if you don't get all that water out, your whole cryostat is going to freeze up. So during that thaw cycle, and your decontamination cycle, if you're using 70%, you're going to come back in the next morning, and your cryostat's going to be frozen solid on the inside because all that water evaporation has frozen up your cryostat. So please don't do that. We decontaminate with 100% alcohol and 100% alcohol only. So each night, you're going to go through that thawing process. It's an automatic timed program that's in the cryostat. And each night it will thaw, all that stuff will run down to the bottom, and down a little tubey into the bucket. And you need to keep your eye on in that bucket is bleach. And so you need to make sure that you're not overflowing that bucket. And then you need to decontaminate it weekly, and that's on our Friday taskmaster list. So how do you actually cut on the cryostat? So once you get your tissue mounted, as we just discussed, after you've waited for that block to cool, and while that cooling process is happening, you're going to utilize that time to build your slide. So on your slide, you're going to have the patient last name, first initial, the date, your initials. That's constant. Then, if there's additional information. You know, you're going to write that on the slide as well. An example would be, you know, ORO. ORO stands for oil red O, and it's a fat demonstration stain that we do. So you're going to take that chuck and you're going to put it in the chuck holder and you're going to tighten it down. And then close your cryostat, okay? Because you don't want your block to warm up. So close your cryostat. And then you're going to use the fine feed to bring that face down to blade level, okay? Then use your coarse feed to either bring it forward or bring it back until that block just barely touches your knife, okay? Then again, you need to learn to pat your head, rub your stomach. So you're going to turn that fine feed while sort of adjusting the thickness on the coarse feed. That's while you're facing into the block. Now you can also use that fine feed to just face into the block, depending upon how close to the surface your section is in your block, how close to the OCT. You know, if you've got a bunch of OCT laying over the front of your tissue, you're going to want to use your coarse feed to sort of get rid of that so that you can expose the tissue just like you would on the microtome. But if your tissue is really close to the surface, then just use your fine feed, several times to expose that tissue. Now, once you've exposed that tissue and you're actually ready to start cutting, that's when you need to open the door to your cryostat. Now, note, you're not making a ribbon. You are never making a ribbon. When you cut on the cryostat, it is one section that's going to roll out and you're going to pick it up on a slide. Okay, so you're going to take a paintbrush. It depends on which hand you are dominant with or not dominant with. I am right-handed, but I put my paintbrush in my left hand because I'm going to use my right hand on my fine feed. And then you're just going to slowly roll that fine feed. Well, while it's coming off, you use your paintbrush to sort of peel that section down onto the faceplate as it's coming off. I always, once I'm past the tissue, I always sort of let it hang on the very top of the block as it's rolled down and it's laying flat. Then you're going to pick up your slide that you've already built and you're going to go down into the cryostat and just lay it on top of that section. It's going to go and it's going to suck right up to your slide. The reason that I put my slide up there and sort of hanging off of the cryostat is because for me, I find that when that section rolls down, if I lift my head to grab that slide, that's when I'm going to lift my paintbrush that's in the cryostat, and my section then is going to roll backwards and I'm going to lose it. Okay. So you're just, if you can imagine sitting at the microtome and you just want the very first section, right? And you have your paintbrush, and you're just sort of teasing that section down the faceplate. That's exactly what you're doing in the cryostat every single time. If your block, has, you're having trouble getting a section and it just sort of keeps gooping up and you've had that door open for a while, give up. Okay, I'm telling you, give up, close the door, wait a few seconds, because it's just like the blocks on the paraffin embedded microtomes. The face against the blade creates friction. So it's going to warm up that section. And so by just simply closing the cryostat for a couple of minutes, and well, I wouldn't go minutes, I would go, 20 seconds or so, and then opening it up, it's gonna again freeze that face of the block, so that you can get a better section. Once you have picked up the section on your slide, immediately you need to just simply take that section, that slide, the back of the slide, and put it up against the palm of your hand. The heat from the palm of your hand will help the section sort of stick to the slide. Okay, it's gonna sort of do that adhesion for you. The other thing that I do is I'll put it right up against the back of my hand, and then on the left-hand side of your cryostat, there's a little lamp, a little light bulb lamp. You can put the back of the slide up against the palm of your hand and then hold it up against the lamp, and you can literally see the OCT just sort of melt away. That is sort of your deparaffinization process, although it's not paraffin, it's OCT. It's meant to melt quickly and melt quickly with heat, okay? And then you're going to stain and mount it. So there are some, and we'll talk about staining and stuff in a minute. So there are some block problems that you may run into. Sometimes if you're too aggressive with your fine feed, or you're trying to face in with your coarse feed and you're trying to face in with your fine feed, the whole, here's your chuck, right? And when I say that, I'm talking about the not the microtome chuck that's back here, but the portion that's got the little peg on it. Sometimes, if you're too aggressive, the whole face of your OCT is just going to go pop right off. So you can actually reattach that. You don't have to rebuild a block. You don't have to panic. All you do is you get another chuck, you put a little OCT on it, you take that specimen that popped off and you just place it right back down on it, and then let it freeze back together. And then you can put it back in and start to recut it. So this is what OCT looks like. So there's a fair amount of OCT that you need to use, but it it's like embedding at the embedding center. There's an appropriate amount that you put into that mold, right? But try as best you can to not get OCT everywhere. Okay. The more OCT that's sort of flying around the cryostat, everything is going to freeze in there and then it's going to goop up in the bottom of your cryostat. So use the appropriate amount. Don't use too little. Don't use too much. Okay. These are the chucks that I'm talking about. So these are, these are the chucks that are gonna go into, see how they have a little peg on the back of them? So these, you're gonna put the little peg, when you're embedding it, you're gonna put the little peg down, and then you're gonna put a little bit of OCT on this. It's gonna start to turn white. Then you're gonna put your specimen on it. Then you're gonna cover the specimen with OCT. Then you're going to put your heat extractor on top of it. Once it's done, this little peg then is now holding your, this little chuck is holding your specimen. And then this little peg goes into the chuck in the microtome. And that's how, and you unscrew it and screw it back in until it's nice and holding there. And then you start cutting. So I've got some YouTube videos, well, some videos for you to watch that demonstrate to you how to cut on the microtome, demonstrate it to you how to embed. So this one is actually our cryostat. It's a tutorial for our cryostat so that you become familiar with where things are. This one, there's this thing that's called disposable molds, that we may have 5 or 6 of them running around, and they are like little plastic cups, that you can take your tissue and you can put your tissue right into the little plastic cup and then cover it with OCT, and then you kind of go upside down and put your mold on the top of it and it freezes, and then you can turn it this way and sort of peel this little plastic cup off the top of it, and you have a nice flat specimen. They're fantastic, but again, they're disposable. And so you can't always rely on the hope that when you get out into industry, that you're going to have disposable molds available to you. So you do need to, if you're using these, you do need to sort of master the building of your own block before you rely on disposable molds. And then this one is how to cut a block. Okay, so it shows you the inside of the microtome. It shows you sort of how it peels off, how to pick it up on a slide, that sort of thing. So this one, then there's this thing that's called a rake. And I personally don't necessarily like it, but some people do. And our cryostat is indeed fit with a rake. So it's this little gadget that sits up on the back of the mold, okay, or your chuck that's in the cryostat, and it's got prongs on it. So you can flip it over and you can sort of lay it at the bottom of uh, your OCT, your frozen OCT. And then when you turn the fine feed, the rake sort of peels that section down for you instead of using a paintbrush to peel that section down the faceplate. So they're great. Yeah, I don't like them. Some people adore them. Yeah, I would rather have my own control with my own paintbrush. But again, if you're, going to utilize the rake, that's great. But make sure that you can also manipulate the sections with a paintbrush, because when you go out there, there may not be a rake on your cryostat. So, staining information. Yeah, so we are going to stain our sections, progressively with frozen sections. So it's much quicker. Remember, we're on a time constraint here, okay? There is no D-paraffin hydrate necessary because we are not in paraffin. So there's no paraffin to remove, and your specimen hasn't previously been dehydrated through processing. So there's no need to hydrate it back to water. So when we are staining with frozen sections, you are not timing yourself like you have done with paraffin embedded sections. You are going to use your eyeballs to determine endpoints, okay? The dyes themselves and the solutions themselves are going to react and absorb much quicker because we haven't processed these tissues. So the absorption rate is much quicker. So again, the first thing you're going to do is melt that OCT. So You've come out of the cryostat, you've got your section. I hold it up to the palm of my hand and potentially underneath the little light until you see that OCT melt. You will see that white OCT turn clear. Okay. At that point, you're good to go. So the first thing that you're going to do, this is your stain line. So the first thing that you're going to do is you're going to go into an 80% alcohol. And we're talking dipping here. We're talking dip, dip, dip. Students tend to want to use a rack to go through their stain line. Don't. It takes up your way more time. It has much more carryover. And hold it in your hand. Hold it on the label. It's so much more efficient. You just stick your section into 80%. We're talking dippy, 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 dippy. And the 80% is going to wash away, window pane away, that OCT. Once you see that happen, you're moving on. So you're going to go into water until your window painting goes away. And we're talking dipping here. So, dippy, dippy, dippy in 80. Oh, OCT's gone. Dippy, dippy, dippy in water. Oh, look at that. The alcohol's gone. Boom, I'm in hematoxylin. You hold your hand in the hematoxylin, you can swish it back and forth. And we're talking, sometimes 30 seconds to 2 minutes max. Yeah. And then as you're dipping it, I swish it back and forth. I'll come up and down. Just because of that agitation is going to help that nuclear stain absorb. Then boom, we're moving on and we're going to water and we're just going up and down until you see your slide come clear. Now, excuse me, that water, you have to change your water after every single slide that goes through there. Because if not, then your water is going to be contaminated with the hematoxylin and your slide's never going to get cleared of hematoxylin. So make sure you're changing that slide or that water all the time. Okay. So we're going up and down, we're watching the slide. Your eyes are your end point. You're watching the slide until all the hematoxylin comes off of your slide. And boom, we're moving on. Now we're going into bluing. When you come out of that water and you look at that slide, you're going to see that it's the hematoxylin is that browny red color. Okay. So washy, washy, washy. Don't assume that it's going to be purple. It's going to be a brown red color. I'm telling you, the minute that you stick it into the bluing, it's up, down, you watch that color. The second that it turns purple, you're moving on. You're going into water. You're going to watch for that window painting to go away and that bluing, you're stopping that bluing. So when that window painting goes away, and your slide runs clean, you're into eosin. The eosin is going to vary lab to lab. It's sort of predetermined the depthness of what they want the eosin to be, but usually it's around 20 seconds. I mean, we're talking ding, 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 ding. I'm out. Again, I look at it constantly. Every time it comes up, I'm looking at the depth of that eosin stain. When I see it to a good, orangey pink color, I'm out. I go into the 95 5 or 6 times. Then you're gonna, because that 95 is your diff of your eosin. Then you're gonna go into 100. Boom, 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 boom. You're just cleaning off that slide and dehydrating it. Boom, 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 into another 100. Then you're going to hit xylene. It's 5 or 6 dips in the first xylene, 5 or 6 dips in the second xylene. Bang, I'm in my safety net. So at my safety net point, I can either cover slip from there, or I can go into an additional Copeland jar that's over at the hood that's right next to the stain line. It's the small hood. We use the small hood for frozen sectioning. And you'll have a hand cover slipping station set up at the small hood. I usually have a Copeland jar of xylene sitting there. So bang, 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 first xylene, bang, 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 second xylene, bang, 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 third xylene. I drop my slide into that cover slipping uh, uh, xylene. And now I'm, getting ready to hand cover slip. So I pull my cover slip, I put it down, put my media on it, and bang, I've cover slipped. And don't muck around with your cover slips. Don't try to, wipe the back. I mean, of course, walk the dog, wipe the back of it. Take a look. If you can quickly get a bubble out, great. If not, leave it alone. You're under a time constraint. So, if there's, something that the pathologist can't see through, I mean, you can quickly tap it, walk it again, get the excess media off of it, because there's nothing worse than handing a pathologist a slide that's all goopy. So get that excess media off of it, and blang, you hand it to that pathologist. At this point, you wait. You just sort of hover, you don't hover behind the pathologist, but you hand it to the pathologist. The pathologist's going to go to the microscope. You can sort of start, changing your water, from your stain line. You can clean up your mess, but don't take that specimen out of the chuck until you get the final words. Now, the final words are put it through. That's your golden sentence. That means that he's seen what he needed to see microscopically, and there's nothing more that we need to do. So, there are reasons why we need to wait here. Maybe that pathologist doesn't see what they expected to see. Maybe it's a bad stain. Maybe it's a thick cut. And they're going to say, can you get me another cut? Well, if you've already taken that chuck out, now you've messed with the face of that chuck, right? So leave it in the cryostat till you get the golden words. Put it through. Maybe there was poor cover slipping. Maybe you drug water into your xylenes, which you've really, with frozen sectioning, because you're going so fast, it's very easy to do. So make sure you are constantly sort of monitoring that frozen section stain line, to make sure that you're not dragging water into your xylenes. Again, maybe it's a poor cut. Maybe he needs to see deeper. He or she needs to see deeper. Maybe they're going to ask you for another cut. They could potentially ask you to go back and get them a couple more levels where, you're going to have to, dig in a little bit and take another section, and then dig in a little bit and take another section. I mean, there's all sorts of things. Maybe he or she is going to say, well, all right, we need to do a fat demonstration on this, or we need to cut enzyme on this, or, we need to do IF on this. IF is immunofluorescence. So you always wait for those golden words, okay? Once you get the put it through, then you're going to go back and you are going to remove the chuck from the chuck holder. You're going to take it to the grow station, and you're going to warm that chuck to release the OCT off of the chuck. So there's a couple ways to do this. You can simply hold it in a gloved hand to warm that OCT for it to fall off. You can run it under water, or you can just leave it at room temperature for a few minutes at the grow station. And while you're cleaning up your mess, and then come back to it. Yeah. If you do leave it at the growth station, for a few minutes, you need to write right next to it on the puppy pad, the patient's name or identifier, so that if it does fall off and you're not right there when it falls off, yeah, you know exactly who it is and what's happening. I personally run it underwater because I know that it's going to go through that dehydration process on the uh, processor. Okay. So I just have a little tiny trickle of water. I'll just dribble a little bit of water on it. Yeah. And then slide it off right into my cassette. So you're going to slide that whole thing off of there. You're going to put it into a cassette. You're going to close the cassette. And then you are going to put it through for routine processing. Now, if you don't have an accession number at that point, which happens, then you're going to put the patient name on the side of the cassette, okay? And that would be first initial, last name, to temporarily label that cassette, yeah, until you do have an accession number. Now, that cassette, you have to remember that this tissue has not been fixed, okay? So when you place it into holding, that holding solution needs to be a fixative. So it needs to be NBF. This is not the same as, the tissues that you place in your 70% holding. So when you're running frozen sections, you need to have a little tiny holding rack in a little tiny tub with a lid on it that has NBF in it. Or you can use one of the glass boats. That's probably even better. To use one of the little glass boats with NBF in it, and you drop your cassette in there to let it fix. And then at the end of the day, you transfer your cassette to the 70% holding so that it goes on the processor overnight. Now, I am talking here real world. So when you guys are required to, I think Jazz has you doing 2 permanents on your frozens, which means that you're actually only going to process 2 of your cassettes. It's either 1 or 2. Might be 3. I'm not sure, but just a few of them. You're not going to process every single frozen that you're doing throughout this entire exercise, because you're going to be doing a lot of frozens to bring your time into that 8 to 10 minute window. So, glass tub, lid, NBF, fix them, and then process them, embed them, cut them, and do an H&E slide on them. And then you're going to compare them microscopically. They're going to look completely different. But in the real world, you would process every single one of them, as well as the remaining specimen, gets, that accession number, right? And then it gets grossed normally, and more cassettes are going to go through processing with that frozen section. Once you have that accession number and that case gets grossed, you're going to put the accession number on the frozen section, and it's going to go with the case on the processor. After you've fixed it, okay? Yeah, and then when it comes out the next day, all of those are going to get cut. All of those are going to get an H&E. And then at QA/QC, the frozen section that you did the day before needs to go with that case, because the pathologist has to look at the frozen section and the diagnosis that he gave that frozen section. And then he's going to look at the rest of the case to assure that his original diagnosis on the frozen is correct. Okay, so that frozen slide has to go with the case into the pathologist the next day. All right, so how do we decontaminate the cryostat? So you're going to wipe all the debris to the bottom of the cryostat. You're going to make sure that the little drain hole in it is not obstructed, and then you're going to thaw the cryostat. Everything's going to go down. There's still going to be goop left. So you're going to take a paper towel with 100% alcohol, and you're going to wipe all the surfaces down inside of the cryostat. Then you're going to go back over those surfaces with a dry towel to make sure that all the alcohol is out. That is very, very important, to make sure that your cryostat is dry before you close the door and you turn your cryostat back on. On the back of the cryostat is a toggle switch, an on-off toggle switch. That's all you need to do when you thaw your cryostat, is turn off that toggle switch. And then when you're done decontaminating, you turn it back on. And there is a weekly decontamination log hanging on the wall next to the cryostat. You have to fill that out. CAP requires you to decontaminate your cryostat once a week. So we do it every Friday. Now, if you're lucky, you're going to have one of the brand new Fandangle cryostats, which is really cool because they have just this simple button that you go boop, and a UV light comes on, and that UV light decontaminates your cryostat for you. But we don't have it, so you get the pleasure of decontaminating the cryostat. Now, there are special stains, that we run, on frozen section tissue. So we have an oil red O, that's for fat demonstration. We have a Sudan black B, which is for fat demonstration. We have a Cahals, which is for astrocytic feet, that's brain. You have a GMS, which stands for Gro-Cots methylamine silver, that's for fungus. You have a PAS, which is a periodic acid shifts. And then you have enzyme histology and immunofluorescence. So that's the basics of how to go about utilizing the cryostat. Don't forget to go back and watch those videos that I've embedded in your PowerPoint for you. And happy studying, happy frozen sectioning. And the next lecture that you need to watch is the frozen section special stain lecture. Bye for now.